Good afternoon. Welcome to Medical Grand Rounds. We have a small but mighty crowd here at Parnassus, and I think about 50 people online, and number is growing, so thank you all for joining us, whichever way you are. Our discussion today is updates in anticoagulation. As Tracy's heard me say many times, when she took the role of helping to lead our work in anticoagulation, I said to her probably 10 years ago, what are you going to do now that there are these wonderful new drugs coming out? There's really no complexity going to be left in decision making. That was among the stupider things I've said in my career, and turns out to be wildly untrue. Things have gotten, if anything, more complex and more interesting. And we have three of our wonderful experts who teach all of us about this to talk to us today about this topic. Very briefly, the first is going to be Margaret Fang. Margaret is professor of medicine. She is chief of the Division of Hospital Medicine here at UCSF Health. She's also medical director of the UCSF Anticoagulation Clinic, and she's a nationally and world-renowned researcher in the use of anticoagulants safely in all sorts of populations, but with a special focus on elderly folks. The second speaker will be Tracy Minichiello. Tracy is professor of medicine and chief of the Anticoagulation and Thrombosis Service within the Division of Hematology and Oncology at our San Francisco VA health system. And Tracy, for many, many years, has been a go-to expert on all things anticoagulation, and she has really transformed the VA in that regard. And last but very much not least is Andy Leavitt, who is professor of medicine and laboratory medicine and director of the UCSF Adult Hemophilia Treatment Center, and also a nationally and internationally known expert in the field of hematology with this part of it, anticoagulation being a substantial piece of what he teaches us all about and does research on as well. So we have a tag team, and I think Margaret is going to start. Margaret.
I'm so delighted to be here for Medicine Grand Rounds and talking about a topic that's really near and dear to my heart, which is anticoagulation. And as you heard, we're going to be tag teaming today and talking about some of the latest developments in the field. I first want to give a shout out and a debt of gratitude to my home division, the Division of Hospital Medicine at UCSF Health, as well as to my fantastic interprofessional colleagues in the UCSF Anticoagulation Clinic, because it is their cases and questions which have inspired me to think about these topics, and some of the cases I'll be talking about come straight from our work as hospitalists and as anticoagulation providers. The three main topics that we're going to be covering today, I'm going to get us started by talking about the use of direct oral anticoagulants, or DOACs, for atrial fibrillation and venous thrombosis in people with end-stage kidney disease on dialysis. Next, Dr. Minichiello will talk about the role of thrombophilia workup, and we will conclude the session with a lecture on the emerging anticoagulants that target factor 11, Dr. Leavitt. But let's get started with this question of using these newer anticoagulants, direct oral anticoagulants in dialysis. And I want you to imagine that you're in the hospital. You're rounding on a 75-year-old woman. She has diabetes, atrial fibrillation on chronic warfarin, and she's on hemodialysis for end-stage kidney disease. She was admitted for cellulitis and now is ready for discharge. And as you're preparing her discharge medications, setting her up with close anticoagulation clinic follow-ups and she's on new antibiotics, she asks you, hey, I really hate taking warfarin, and I heard on television I should ask my healthcare provider if a new blood thinner is right for me. What do you think? What do you say? Oh, warfarin isn't so bad. You should stay on it. You're on dialysis. Or do you say, yeah, it's okay to switch to a different anticoagulant. Let's start you on apixaban. Or do you say, let's get you home. You should talk this over with your primary care provider. No, hospitalists wouldn't do that. Why are we talking about this issue of DOACs in end-stage kidney disease? DOACs are now the most commonly prescribed new anticoagulants in the United States. They're the first-line recommended treatment for atrial fibrillation and venous thrombosis, except in end-stage kidney disease. And that's because people on dialysis were excluded from those original clinical trials. And it's because all of the DOACs, to at least some degree, are renally cleared. And we worry that anticoagulant concentrations are going to be elevated, and that's going to lead to bleeding risk. Nevertheless, just like DOAC use has been increasing in the rest of the population, it's happening in dialysis patients as well. And a study from a number of years ago showed that more than a quarter of new anticoagulant prescriptions in patients on dialysis with AFib were for apixaban. Should you be using DOACs for AFib in end-stage kidney disease? Well, there were 3 recent multi-centered randomized trials that addressed this very question. And these are the renal AF trial, the Exadia AF trial, and the Valkyrie trials. In all 3 of these trials, the investigators enrolled people on chronic hemodialysis who had atrial fibrillation and an indication for anticoagulation, and randomized them to either a DOAC versus a vitamin K antagonist like warfarin. 2 of the trials, they used apixaban, one of them at a lower dose, and the 3rd trial, the Valkyrie trial, used a lower dose of rivaroxaban. And remember, we're thinking about safety here. So the primary outcomes they were looking at were the complications of anticoagulants, bleeding, death. The Valkyrie trial did look at vascular calcification, but they also reported safety, so that's what we're going to focus on today. Who were these people? Well, first, I just want to point out it was really hard to recruit people for these studies. The renal AF trial wanted to enroll 760, but only managed to get 154 by the end of the study. Exadia, less than half of the desired number were enrolled. So just a caveat that these ended up being pretty small trials. Who were they? They reflected the people that we manage on dialysis, tended to be older, and they tended to have a lot of risk factors for stroke, SFVAHCS 4 and higher. And the range of follow-up ranged from 1 year to as long as 5 years. Let's go over some of the outcomes of these trials. I think the first striking finding is that people with end-stage kidney disease are very sick. And no matter if you were in the DOAC arm or the warfarin, the vitamin K antagonist arm, your rate of death by the end of the follow-up period was really high, 20%, 40%. What about bleeding? Well, here, there's some reassuring data for the DOACs. In each of these trials, the patients who were randomized to the DOACs had no significantly different rate of bleeding, either major or non-major, compared to the patients who were on vitamin K antagonists. So actually quite reassuring. And then looking at stroke, no statistically significant difference either. So these are reassuring trials. Even though they were small, they show us that at least there's no increased risk of bleeding associated with DOACs in people on dialysis. Now, they are small, so this is where I look at the observational data, and in a recent meta-analysis of more than 70,000 people on dialysis and looking at the role of anticoagulants, they found that apixaban, compared to warfarin, was actually associated with a lower risk of death. And looking at the safety outcomes of bleeding, apixaban, again, lower risk of bleeding as well. Rivaroxaban, on the other hand, had no difference in bleeding compared to warfarin. So this meta-analysis of what's happening in observational studies shows that apixaban may actually be safer than warfarin. So how do we apply this to our case? The question, can you use DOACs in dialysis? And based on the evidence to date, the answer seems to be yes, even though the randomized trials were underpowered. Now, if you are going to use a DOAC in dialysis, I would recommend that you use apixaban. That's where the strongest evidence about safety is found. And then a final caveat, as we saw, bleeding risk, death is really high in people on dialysis. And this question of whether you should be anticoagulating people on dialysis for AFib at all is still an open one and being addressed by ongoing clinical trials. So you discharge your patient on apixaban. She's very happy with you. And the next day, you take over another inpatient service. And again, you have another situation where you have someone on dialysis, hospitalized now for a lower extremity DVT. He's been on heparin for 7 days, still not therapeutic on the warfarin. And your hospital is at capacity and you're wondering whether there are alternatives to try to discharge him home. What do you do? Oh, just stay on heparin, it's only going to be a couple more days. Or do you change this anticoagulant to apixaban and discharge your patient home? So we just went over the data on atrial fibrillation and apixaban and DOACs. And now the question is, should you be using apixaban in acute venous thrombosis? And this question was addressed by this observational study published in the Journal of Hospital Medicine that looked at a national cohort of patients who were on dialysis. And of these almost 12,000 patients, they looked at what was happening in clinical practice. And they found that 20% of them were prescribed apixaban around the time that they got a diagnosis code for venous thrombosis, and 80% were prescribed warfarin. So the investigators decided to look at were there differences in bleeding and recurrent VTE between these two groups. And because they're not randomly assigned to one anticoagulant or another, they used statistical methods to try to balance out these factors. Some findings that jumped out to me from the study first. One is use of apixaban is also rising in venous thrombosis and dialysis. In 2014, that was only 2% of the prescriptions, and by 2018, almost half of prescriptions were for apixaban. So it's happening in clinical practice. The next is an interesting one, which is that the dose that clinicians are using is lower than what's actually recommended for acute VTE. Now remember, for apixaban, you have this loading period of a higher dose, followed by a maintenance period of 5 milligrams BID. But we're finding in this study that many people are using low-dose apixaban at 2.5 milligrams, which is really more the atrial fibrillation treatment, not acute VTE. Who were the people in this study? You can see that the average age between the apixaban users and the warfarin users was about the same. Most people were on hemodialysis. Many people had a prior history of VTE. Many people had bleeding. Just to highlight that people with dialysis have a high risk of thrombosis and bleeding. What were the outcomes? First, remember, we're looking for, is it safe to use apixaban in acute VTE? And here we find that the apixaban users had a lower risk of major bleeding, a lower risk of intracranial hemorrhage, a lower risk of clinically relevant non-major bleeding. So quite reassuring. And then when you look at recurrent VTE and death, no differences between apixaban users and warfarin users. So again, this is a reassuring study that says maybe apixaban might even be safer than warfarin in acute VTE as well. One question, though, that came up is the dose of apixaban. And as I mentioned, the loading period for apixaban is 1 week at 10 milligrams twice daily, followed by a maintenance dose. We are worried about this because there are small pharmacokinetic studies that show if you're giving even just the 5 milligram BID of apixaban in people on dialysis, the concentrations actually become supratherapeutic. So what do clinicians actually do in practice? Here is a retrospective study of about 200 patients from the University of California Health Systems, including some of the patients here at UCSF. And the investigators looked to see what was being done with loading dose and maintenance dose in acute VTE for people on apixaban who had dialysis. And they found that only a quarter of patients actually received a loading dose, and that a lot of patients actually receive the lower maintenance dose as well. Is there a difference in outcomes? Here, again, not randomized, but in the standard dosing versus the reduced dosing, standard VTE dosing was associated with a higher risk of clinically important bleeding and hospitalization for bleeding, and no benefits in terms of recurrent VTE risk. To our case, and should you be using apixaban for acute VTE and end-stage kidney disease? The answer seems to be, again, yes. Apixaban is a reasonable alternative to warfarin with a few caveats. Use with caution in people with a high bleeding risk. We don't know what the ideal dose is, especially in the loading period. And there are circumstances where heparin and warfarin is still the preferred anticoagulant treatment. Thank you so much. I'd like to welcome our next speaker, Dr. Tracy Minichiello.
Thank you, Margaret. That was a fantastic tour of a very controversial and confusing topic. So we're going to talk about the thrombophilia evaluation. I have no financial disclosures, but I do want to send out a lot of gratitude to Dr. Stefan Mahl from UNC. He's a hematologist who did a lot of the work in this area that we're going to talk about and has shared some figures and slides with me that are fantastic. So we'll start with a case. 36-year-old woman, she's on oral contraceptive therapy, and this is a combined agent, so there's estrogen plus progesterone. She's been on it for many years. And 3 months ago, she develops bilateral pulmonary embolism. She's on rivaroxaban 20 a day, so she's on her maintenance dose, and she comes in for follow-up. She's otherwise healthy. She has no other medical history. She's not on any other medications now. She stopped her oral contraceptive therapy. And before the PE, she had no immobilization, no hospitalization, no trauma, nothing. Should you send a thrombophilia workup? So you say, yes, why not? She's here. Or you say, no, then I'm going to have to interpret it, and who needs that? So let's talk about why we would do a thrombophilia workup. So there's generally two scenarios when we're thinking about this: someone who's already had a clot or someone who hasn't had a clot and has a family history. So primary prevention, that's a person who has someone in their family who's had VTE and they've been found to have thrombophilia, and they come to you and they want to know, should they be tested? And we might consider that because we might use that information to give anticoagulation to prevent clots in the future in certain scenarios. But the more common scenario, and the one that we're going to talk about today, is somebody who's already had thrombosis. And the reason we might consider that is because maybe that information will help us think about duration of anticoagulation, or maybe that information will help us choose anticoagulation itself. When I say thrombophilia tests here in this discussion, I'm talking about the most commonly sent thrombophilia tests and the ones that we know have association with VTE. So I'm talking about the inherited deficiencies of protein C, protein S, and antithrombin, and the gain of function mutations, factor V Leiden, and prothrombin gene mutation. And then I'm also talking about acquired thrombophilia, specifically antiphospholipid syndrome. So on this slide, you can see the tests that we send for each of these disorders. So the big question is who? Who should we test? And that we get a lot of consult questions about this. And this is where I want to thank Stefan Moll, because I really like this figure. It really kind of helps you get your head around how you're going to potentially use the thrombophilia workup. And in order to do that, you really want to understand recurrence risk of VTE in various clinical situations. So at the tippity top of the triangle is going to be the lowest risk of recurrence after a course of anticoagulation. And at the base, the broad base, is the highest risk of recurrence. And along the side here, you see suggested duration of therapy. So a defined course of therapy at the top of the triangle if you have a low risk of recurrence, and extended duration if you have a high risk of recurrence. So just to bring your attention to the top of the triangle, the very top are patients who have a VTE related to a major surgical risk factor. They have a very low risk of recurrence. And I'm not sure if you can squint and see it, but the recurrence risk is really low. In the first year off therapy, 1%. The next 5 years off therapy, 3%. So really low recurrence risk. A defined course of anticoagulation makes a lot of sense. So drop your eyes down to the base of the triangle, a man with an unprovoked VTE, and men have a higher risk of recurrence than women. Their recurrence risk in the first year off therapy, and this is with a single unprovoked event, is 10% in the first year off therapy and 30% in the next 5. So that leads to this recommendation to extended duration anticoagulation. But the dotted line breaks between a defined course and extended duration. And you can see the folks that are here, women who've had thrombosis in the setting of hormones, be it contraceptive therapy or pregnancy or non-major transient risk factors. So this is where the American Society of Hematology thrombophilia guidelines come in and can be helpful. They've just published these, and just to disclose, not a lot of data to guide these here. These are suggestions, conditional recommendations, and of course should not replace clinical judgment, but there's a low certainty of evidence around this. This is a very detailed document. It's 124 pages. We'll go through every page today. So the QR code will take you there if you're interested. We're just going to talk about those patients who have VTE and how we can use that to help us. So let's start with when they say not to test, because the idea here is to be selective about the use of these tests and intentional and make sure they're going to impact your management. So when should we not test? Well, if you're already at the base of that triangle, you already know you have a high recurrence risk and you're going to offer ongoing anticoagulation. There's really no role for sending this testing. The flip side is if you're at the top of the triangle with a surgically associated thrombosis and you know a defined course of anticoagulation is indicated, you're not going to gain something from testing. And this is really what the ASH guidelines are talking about. In whom would it make sense? Would there be a net clinical benefit to change your management based on these results? So it's neither of these scenarios, but it is this scenario in the middle here. This women on hormones and women and other patients who've had non-major transient risk factors. And this is what they're talking about. So a surgically associated thrombosis, but not from a long surgery and not a major complicated surgery, or a patient who's had a thrombosis from another non-surgical risk factor or hormone-associated thrombosis, and people who have clots in weird places. And weird places are anything other than your leg and your lung. That's a clot in a weird place. So that's the conditional suggestion to test in these patients if it's going to impact your management. And just a little more granularity on these risk factors in these patients. These are patients who are hospitalized maybe with pneumonia for 3 days. They're not walking around. They have intermediate recurrence risk. A patient who has a clot in the setting of OCPs or pregnancy, intermediate recurrence risk, or immobilization, cast immobilization, long haul air travel. These are the folks that we're talking about where you might use some of this information to guide your management. So how would I interpret this testing if I chose to do it? Well, if I find strong thrombophilia or antiphospholipid syndrome, acquired thrombophilia, I'd be more inclined to move this patient down in the triangle and think about extended duration therapy, whereas if they did not, I may be more inclined to offer a defined course of anticoagulation. And just so we're on the same page with regards to strong thrombophilia, that's protein C, protein S, and antithrombin deficiency, and a true confirmed antiphospholipid syndrome. So let's talk about when to test. And the when is important. Remember that I just said severe thrombophilia is protein C, protein S, antithrombin deficiency. Those are the ones you really care about. Factor V Leiden and prothrombin gene mutation in the heterozygous form are relatively wimpy risk factors for clotting, so they're not really going to influence your therapy quite as much unless they're homozygous, which you won't see as often. But protein C, protein S, and antithrombin are decreased in the setting of acute thrombosis. And protein C, protein S, antithrombin, and lupus anticoagulant are not reliable in the setting of anticoagulation. So you can't send a lot of these things in the throes of an acute thrombosis. So when to test? Not during an acute thrombosis. The one exception I will say is if you're considering somebody who you have a strong suspicion for antiphospholipid syndrome, and that I mean they have lupus, they have multiple obstetric complications, they have livedo and thrombocytopenia, they have arterial and venous thrombosis at the same time. Real strong clinical suspicion, that might be reasonable because recent data show that these patients likely should be treated with warfarin instead of a DOAC because of increased rate of arterial thrombosis. But for most people, you don't send the thrombophilia outright, and I wouldn't send it to determine their anticoagulant if you don't have a suspicion for APS. But if you are going to send it, we think about doing that after the course of therapy, so 3 to 6 months, and then we're talking about whether you're staying on or whether you're going to continue, or we need more information to modify that. So this is when we would send the testing. In this box here, you can see the testing that you can send reliably while on anticoagulation, but you notice it's not all the tests. So you can get genetics because you can get them at any time, and the free protein S, and the antibodies for antiphospholipid syndrome. But to send the rest of the assays, you'd have to hold anticoagulation for between 1 and 4 weeks, depending on the anticoagulant you're on. DOACs you could hold for a week, you can get all of this information, but warfarin, remember, protein C and S are vitamin K dependent factors, so they can take 2, 3, or more weeks to reconstitute. So in some cases, you're holding for a longer period of time. So just to pause for a moment to talk about antiphospholipid syndrome, because I did mention that. Until recently, we've used the Sapporo criteria to make this diagnosis. So patients are suspected of having antiphospholipid syndrome if they have a clinical criteria, which means an acute arterial or venous thrombosis or obstetrical complications, as well as lab criteria. A positive lupus anticoagulant that's persistently positive over 12 weeks, or a beta-2 glycoprotein, IgG or IgM, or an anticardiolipin, IgG, IgM. But what we've appreciated over the years is that the Sapporo criteria aren't very specific. We don't like to label people as APS if they're not APS. So we don't have great specificity there. There's also other clinical manifestations that aren't included in this, and it hasn't been that helpful with kind of grading how important a positive lab test is, lupus anticoagulant, say, versus an IgM beta-2 glycoprotein. So these are the new criteria for APS. Again, you can scan the QR code. Here's the good news, much more specific. Are you ready for the bad news? Much more complicated. So there's this point scoring system. Full disclosure there, but same thing, 1 clinical criteria, 1 lab criteria, but now you have to have 3 points in the clinical domain and 3 points in the lab domain. But don't be upset. I just included a calculator, online calculator right there, so you can just click on that and you can go through those motions if you are considering APS. What I really like about this is not all events are included because they weight them depending on whether there's an associated minor or major risk factor, because you're really looking for otherwise unexplained thrombotic events. So if it's an unexplained VTE or an unexplained arterial event, you get the amount of points that you need to meet the clinical domain, where you wouldn't if it was a provoked, majorly provoked event. So that's why it becomes more specific. Then I also really like how they help you with these lab assays. So if you have persistently positive lupus anticoagulant, you get a lot of points, you meet that clinical domain. But if you have beta-2 glycoprotein IgM in the moderate range, not so much. You get 1 point. You need a lot more to get there. So it does a nice job of making this a lot more specific. They also actually give us numerical ranges. For those of us in the area, we're very appreciative of that. So back to our case. Our 36-year-old woman on OCP has been on it for a long time with her VTE that doesn't appear to be provoked due to anything else. I'm going to send a thrombophilia workup because I want to see if she is harboring a strong thrombophilia. Also, I always wonder about these OCP-induced thromboses when they've been on the OCPs many years. I'm getting suspicious. So you can see she hugs this dotted line. This is the place where maybe the thrombophilia evaluation may help us. So part of the pie, the thrombophilia workup, not the whole story for duration of therapy, right? We think about bleeding risk and patient preference, but it can be helpful. Just remember that it may not be helpful. It's a hard thing to get right. You want to make sure that you have accurate studies, not in the setting of acute thrombosis or anticoagulation. And people can feel stressed by these results, so make sure that you're going to use them. They'll influence your therapy, be it how long a patient will stay on therapy or choice of anticoagulant. Whirlwind tour of thrombophilia. I'm happy to answer questions at the end, and I'm going to hand it over to Dr. Leavitt.
Two tough acts to follow, to say the least. Now, let me make sure I have the process going the right way. Okay, this is it. So I'm Andy Leavitt, and I'm going to switch gears a little bit here. You've just heard two very useful and clear talks that you can use this afternoon in your practice, or literally tomorrow. Now I'm going to shift gears and talk about something that you can't use today or tomorrow, but maybe you can in a year or so. We'll have to see. And that is, I want to talk about factor 11 inhibitors. So the idea of a new class of anticoagulant. And in order to understand tomorrow, which is what new classes would be all about, I think it's good to start with understanding how we got to where we are today and why we actually want to look at things differently tomorrow. Oh, sorry. Rarely have I been told I'm too soft. I better in my voice. So thanks a lot. Sorry about that. Okay, so moving along. No, moving backwards. Okay. So I want to give you three background slides. Okay, the first is a little timeline on parenteral anticoagulants. So we all are familiar with unfractionated heparin, and you'll notice that this was approved by the FDA in 1939. It wasn't until the 1990s that we had another parenteral product, a low molecular weight heparin, and certainly around here, enoxaparin or Lovenox would be the one that we use more than any other. That's a big gap. And for those of us who, say like myself, who medical school and residencies and whatnot in the 80s, I remember someone would come in, they'd have a DVT, and they were there for 2 weeks on unfractionated heparin because you weren't allowed to start warfarin for a few days, and then it took 10 days to get their INRs just right, and they were going crazy and you were going crazy. So this was an enormous advance, the idea of Lovenox and how that changed our ways. And all of us now know that the advances in oral agents, that same person that was there for 14 days literally leaves the ER with a pill, and they don't even have to get admitted many times. So we've made a lot of advances, so why are we trying to do more? Well, I'll get into that in just a second. So I'm not going to belabor the rest of them. It's just to give you an idea of the timeline for all of this. So now let's talk about the oral anticoagulant timeline, because that's what certainly we enjoy, and we've heard about oral anticoagulants here. I want to just give a little historical perspective for warfarin, which was FDA approved in 1954. And once again, we have a 50 to 60 year, we have like a nearly 60-year gap just like with the heparin products, between the first one and the second one. And for those of you who don't recall this or didn't know this, the name comes from the fact that this was developed and understood at the University of Wisconsin. And why was it done there? It was because the cows were bleeding to death because they were eating rotten clover, and they isolated the product, and it ultimately, this was a derivative of that, and it became warfarin. And the reason it's called that, because it was all funded by the Wisconsin Alumni Research Foundation. So that's where that name comes from. And then it wasn't until 2010 that we had a new type of an oral anticoagulant. And these are, as you've heard in the last two talks, referred to as DOACs, for direct oral anticoagulant. And we'll get into that meaning of direct on the next slide. And you'll notice that for those of you who aren't already aware, if you use generic names, you can always remember what the target is, because there's a T in the antithrombins, and there's not that in the anti-10As, and there's always an XA in the name of the anti-10As. And so in this country, largely we use rivaroxaban and apixaban, but all three of those are available. There's another one that came to market, actually, that I didn't put on there, and that company removed it from market, not because of any toxicity, but it didn't, obviously they just couldn't break in, so it was an economic decision, and it left the market. Okay, so there's a little timeline for parenterals and for orals. Now, here comes, nobody leave. Okay, nobody leave, all right? The doors are locked, you got your sandwiches in here, nobody leave, okay? So this is the third backup, just a little reminder, okay? What I view as one of the finest slides of the coagulation cascade, although I know PTSD is happening in some of the seats in this audience and somewhere online as well. Stick with me. So the point, why do I bring this up? Because I want to orient you to the ideas behind the idea of going after factor 11. So what do we have here? We have the coagulation cascade in its basic model, where you have essentially a Y-shaped structure. That is, you have two arms at the top, the intrinsic and extrinsic arms, and they both feed into the common pathway. So if you look at this long enough, you can see a Y shape, almost like an antibody. And the points I want you to take away from this is, in the extrinsic arm, you see the tissue factor as the main stimulus for this process. And in fact, that's probably what starts almost all clotting or hemostasis. And we'll get into the term of hemostasis versus thrombosis in just a second. So I want you to think of the external cascade. And the reason it's called external, because as you can see in this drawing, the tissue factor in this is coming from outside of the vascular space. So it's the extrinsic arm. The intrinsic arm on the other side, with a yellow box behind it, only requires things that are already internal to the circulation. So again, reminding you where these names come from, helping you remember those things. And then the common pathway down below. And the key thing in the common pathway is in the red box, which is the prothrombinase complex, which really is where all the money is, and it drives you down through thrombin, and you get a clot down at the bottom end. And each of the individual arms can drive into the prothrombinase complex, because each can independently activate 10. Right? And remember, one of our new agents is an anti-10A. So let's now layer on this where our new agents are located. So first, let's go with our traditional agent, warfarin. So warfarin affects all four of these clotting factors. So essentially, all three arms are impacted by warfarin. It's felt that probably the biggest factor, though, is its impact on the common pathway. But nonetheless, you can see how it's all over the map. All right. And now you can see that the direct agents directly target a single space, and they're highly specific for those molecules. So you have a direct thrombin inhibitor, and you have anti-10A. Now, again, don't leave, please. This is how this is taught, and this is how we learn it as a fundamental basis when we're in medical school. But there's a lot more complexity to this, and there are feedback loops, and there are things turning off and turning on. And thrombin has so many roles, both in turning on the brakes as well as driving forward on the clot. And a lot of that work was actually done here years ago. But one of the things I do want to add to this that a lot of people don't think of in their fundamental thinking of this cascade going just top to bottom, is that an important thing that's become more and more clear over the decades is that one important role of thrombin is to actually feed back and activate factor 11, such that in certain situations when you start clotting and you start it through the extrinsic cascade, there are mechanisms that gets turned off, and then you drive the thrombosis through the intrinsic arm. So that's a little background. We're done with the background for those 3 slides. Let me move forward. So if we have these wonderful new agents, the first speaker gave a nice talk about how, in fact, we can use these in the setting of people on dialysis, something that was really people were afraid to do when these came out because of their renal clearance, because of concerns of drug accumulation, et cetera, as you've already heard. So the goal of anticoagulation is to do 2 things. It's to attenuate or prevent thrombosis, which is the formation of a clot within the blood vessel, and thereby obstructing blood flow, whether it's arterial or venous, from the disruption of hemostasis, which is the repair of a vascular defect so that you don't exsanguinate. And so one is preventing blood loss, and the other has to do with getting in the way of blood flow. So how do you segregate these if, in fact, on that previous cascade, essentially everything seems like it's going down the same process? So it does seem like it's really going to be difficult. So DOACs have been a huge advance in oral anticoagulation in getting us towards these spaces. And how so, if I can just summarize here? They're at least as effective as warfarin for stroke prevention and atrial fibrillation and venous thromboembolic treatment. And in fact, they all came to market by non-inferiority trials for their efficacy. But when the data were looked at, it was actually there was a lower risk of serious bleeding, including intracranial hemorrhage, and they were more convenient. So this is a huge advance. But can we do better? Are there unmet needs? And the answer to that, and people certainly in medicine always think we can do better, and certainly people in the pharmaceutical industry always think they can do better. We know better than that, but they think they can always do better. And so, yes, there are unmet needs, and there are ways that we could do better. So atrial fib, annual major bleed rates in DOACs, based on the most recent data I could find, it's not a specific area in which I work, are somewhere in the order of 2 to 3%, with intracranial hemorrhages still at 0.3 to 0.5%. And, you know, if that's your intracranial hemorrhage, it's 100%. So that's still a concern, and it impacts decision makings and therefore the use of the drug, or the drugs, and it impacts therefore the prevention of strokes. So it's a tough place. So it's still a problem there, and that leads to something that is a little bit difficult to quantify, but I think the literature supports this, and that is it is this fear of bleeding. Even though you might think those numbers are low, and certainly if the numbers were way higher and you come down to this, people are happy. But once you live at these numbers, people start to not be so happy with those numbers. And so there's a fear of bleeding that's thought to be partly why nearly a third of people on atrial fibrillation aren't on anticoagulation or on too low of a dose based on recommended dosing. So this notion of bleeding is not trivial in the management or the prevention of venous thromboembolic disease. And in addition, there are other places where these drugs haven't proven to be as wonderfully useful. As you heard by the last speaker, people with certain forms of antiphospholipid antibody syndrome should probably not be on a DOAC and should be on warfarin. They never proved health. They were not found to be useful for mechanical heart valves. And then in an area that's very near and dear to my heart, people with venous thromboembolism and malignancy, people with malignancies have higher risks of clotting. They have higher risk of bleeding on anticoagulants. So they're a much tougher group to deal with. And within that group, many of them, the DOACs have proven useful. But in the group with GI luminal cancers and GU cancers, that's not so good because of the higher bleed risk. So that still remains an area where there's need. So there are unmet needs, and we can do better. And it's really in the area of trying to stop the disruption of the hemostasis, but yet getting at the issue of preventing thrombosis. Okay, so why target factor 11 then, if this is what you want to do? All right, if you remember, it was high up on the cascade. It's not in the kind of the main pathway down below. And there are regulatory processes that might influence. But I would say these are probably the most cogent arguments that people use. So in mouse models, if you knock down factor 11, it will protect against thrombosis models in those mice without increasing bleeding. There are primate models in which antibodies to factor 11 inhibit thrombosis without affecting bleeding times. And in knockdown experiments used in primate animals, using siRNA, it can protect from thrombosis without increase in bleeding. And then you have human epidemiologic data. And this is kind of interesting. Factor XI deficiency, or patients with factor XI deficiency, they have reduced risks of cerebral ischemia and venous thromboembolism. So here we have people walking around giving us these ideas that this is a better state to be in from that perspective. Okay. In addition, people who have excess factor XI, there are fewer of these folks to do, so the data are a little thinner there, but it suggests they have an increased risk of venous thromboembolism. So it gives us both sides of the coin. I would say that the first line I find more substantive, but nonetheless, these are points that are used by folks who are promoting factor XI as a target. Factor XI deficient individuals typically do not spontaneously bleed. We have a lot of factor XI deficient patients in our bleeding disorders clinic or hemophilia treatment center, kind of a synonym there. And it's pretty much you have to do something to them to get them to bleed. We need to be around when they're having surgery. We need to be around if they get hit by a car, but in their everyday life, they're doing fine, thank you. And so that says something. That's very different than people who have significantly reduced levels, say, of factor VIII and factor IX. So factor XI deficiency is different than those other more well-known deficiencies. But one of the things that we do need to remember if we're talking about impairing or reducing factor XI activity is there is bleeding with factor XI deficiency, and in particular, it's areas of tissue where there's high fibrinolytic activity, and those two areas are in the kind of oronasopharynx and in the GU tract. So those are places that we need to be looking for in these trials if, in fact, folks who are on something that's impairing factor XI, is that where we're seeing a bleeding signal? So keep that in mind. Okay, so the point is all those data bring us to this question. Might factor XI be essential for thrombosis, but essentially dispensable for hemostasis? Well, there are many pharmaceutical companies who are hoping the answer to that question is yes. Okay, all right, so, okay. I debated putting this figure in here, and in the end, the debate won that said yes. Okay, because this is now taking that slide I used to introduce and taking someone else's cartoon from a recent review on this topic and trying to give you this perspective of hemostasis versus thrombosis within the same concept of the clotting cascade, all right? So what we have on your left is hemostasis. Let's start there. That's where you can see a defect or a rent in the endothelial surface exposing to very high levels of tissue factor in the subendothelial space. And that's why the black arrow heading towards factor VIIa is much more bold and thick. That drives you down into the down into the prothrombinase complex. You go down, you make a hemostatic plug. And this system works much more quickly, they claim, okay? And I think these are arguments driven more off of the epidemiologic data and the animal data. It's a little harder to tease this out in a test tube, but nonetheless, this is the model that is being promoted to promote 11 as why it might be so effective. And so if you go down, you get a plug, and you don't have much of thrombin circulating back to activate factor XI. Remember, the one thing I told you in that earlier slide was to remember there's this thrombin comes back and activates factor XI. In a rapid high tissue factor process, that you don't get nearly as much factor XI activation because the whole system is done quickly. On the flip side, if you have something within the vascular space where there's much less tissue factor exposure, that kind of ignition key, if you will, into factor VIIa and tissue factor is a much lower level process. And you run a lot more dependent on going back through factor XI. And so it's been kind of hypothesized that if this is true, then maybe if we could interrupt that, we'd be having much more impact on the thrombosis and much less impact on the hemostasis. And I will simply say that that pathway that comes down, actually going up to 12 and coming down, of course, is very, very important for the problem of thrombosis when we have intravascular devices, so-called, line clots, et cetera. And of course, that's a space that's being looked at here. But hopefully this visual, maybe, for some of you, can give you some insight into the thoughts behind why targeting 11 might be better. And notice it doesn't touch anything down in the common pathway, which is critically important for hemostasis. Okay, so what is going on in these spaces? I keep saying that there's this keen interest here. So there are clinical trials going on. There are agents and there are settings. What are the agents? There are 3 classes of agents that are in development now. siRNA to knock down the expression of your factor 11. There are small molecule inhibitors, and there are monoclonal antibodies. And so I put across from them the routes of their administration, but I've made larger the settings because any one of these is being looked at by one company or another in any one of those 5 settings that I've shown there. The comment about TKA, I should have written it out as total knee arthroplasty, basically a knee replacement. Essentially, every anticoagulant has to pass through the gauntlet of the total knee replacement in order to understand a sense of efficacy and safety. And the reason is that it's a well-defined situation with a well-known risk factor, and it's a very short period of time that you have to do the analysis. So these things are being tested in that setting, and I'll comment on that in a minute. But what's going on much more aggressively now is the AFib, probably more than anything else, and the other topics that I've mentioned there. So on this slide, I know it's busy. I'm not going to read it. It's to highlight a point, is that you can see everybody went through these arthroplasties, and they're very high-profile journal articles here. And you can see I've listed one of each of the flavors, an siRNA, an antibody, and a small molecule. And basically, they're all effective in preventing the venous thromboembolism. None of them showed that they were actually better at the bleeding risk, just mind you, just to remember that. And in fact, unfortunately for one of them in the editorial, do these findings prove that reduction in factor 11 levels inhibit thrombosis without effect? Well, no. All right. So there was no, they didn't pull any punches there. But nonetheless, they had to pass through this for their safety and efficacy data. Okay. Looking at the time, and so that we have plenty of time, I'm going to assume the clock on the back of the wall is accurate and we're following that. I'm just going to highlight one thing here. This is a table taken from a recent review on this topic. And for example, issues that will be relevant here, we have the antisense RNA, the siRNA. Notice it takes a long time to get on. If you go back and read that article about that use in knee replacements, weeks ahead of time they had to inject it in order to get the reduction of the expression. So there are different aspects of things here that will matter, and including things like renal clearance, hepatic metabolism that you can see over there. So I won't belabor that, but there are going to be issues with each of these classes of molecules. I'm going to highlight one thing here, and I'm going to highlight this study in atrial fibrillation, because the stuff before this, none of them showed that they achieved this notion of reduced bleeding. Okay, and so here was a trial. This was the antibody that was being used, and you can see what they're comparing it to. And they're using rivaroxaban, a stalwart that's used in this area, and they use different different doses. And I put here for those, the cognoscenti that want to know these levels of details, these were serious people needing anticoagulation, and they wanted to pick folks who had higher bleeding risks, okay, to really try to be able to have a sense of improvement. And lo and behold, there was a report that came out in September of this year that this study was stopped because the review board that monitors the safety felt there was such a reduction in the bleeding risk that this trial was stopped. So this is a phase 2 trial that was stopped by the safety board. So that's an interesting tickle that there might be something out there, okay, beyond the hypothesis of why there might be something out there. Of course, you can't get the data yet, okay? You can only get this report from the news and from their websites. But it's intriguing, and I think this gives it a little more oomph that this field may have something for us. But it'll take a long time for us to know if that's true. I'll close. This is my second to the last slide. So currently, this is just a little summary of the phase 3 trials, and you can see the different settings where it's going. Again, this is an area very near and dear to my heart, that is to reduce the bleed risk in patients with cancer and make it easier for them to go. And I'm not going to belabor reading through this. It's just to give you an idea. So to close, I want to just say, so factor 11 as an anticoagulant, as I said, it's not for you this afternoon and it's not for tomorrow, but in the future, you might need to know about these agents. Is this reasonable to pursue? I think the arguments are there that it is reasonable to pursue. Will it solve all of our anticoagulation issues? Absolutely not. That's easy. We're trained in medicine that when All is in the question. The answer is always no. Okay. Might it provide improved bleed risk in selected settings? It very well might. Maybe it will help those folks with cancer. Maybe it'll help those AFib patients with much higher bleed risk so that we can start to get that third of untreated patients treated so that their stroke events will go down. Problems, there will of course be problems, but we'll manage those problems as we go. So with that, I'm going to stop. Thank you for your attention and let our moderator take over. Thank you.
Fabulous. That was really exciting, interesting, lots to learn. Why don't you three of you come up? Maybe we can get 3 chairs here. I have a couple of mics. We start with a few questions of my own. Margaret, the issue of the anticoagulants and dialysis always raises the issue of these patients with bleeding diathesis because your kidneys don't work or your liver doesn't work. Are they protected from clotting or not so much?
So the question about, for example,
like if someone,
liver,
let's say someone has renal failure or someone has liver failure, we always think, well, they have a platelet defect or they're are they auto anticoagulated or are they same risk as people who don't have that?
I think we saw from the studies that if you have chronic kidney disease, you actually have a higher risk of thrombosis and bleeding. So no, you're not protected. Both your risk of thrombosis and bleeding are going to be elevated. And in the setting of liver, and do you get auto anticoagulated? I think the answer is no. We would still do VTE prevention strategies in someone with cirrhosis, and it's probably the combination that the liver generates both prothrombotic and antithrombotic proteins.
Okay,
So,
I see heads nodding there. Tracy, you gave the rationale for checking these thrombophilia tests as it's going to change your clinical management. Is there any rationale for family counseling?
Yes. So this.
Maybe make sure that's on.
Yes. So the American Society of Hematology Thrombophilia guidelines address this because this comes up quite a bit. Should you be tested if you have a family member that tests positive? So you're talking about someone who has not had a thrombosis, correct?
I mean, you framed it as send the test if it's going to change your management for
Yes.
that human, that person. But I think sometimes there's an externality. The person's maybe on the border, maybe it's not on the border. I'm clearly going to anticoagulate them forever. But if I knew for sure there was a genetic defect, that would be useful to know as in terms of family testing and or counseling.
Yes. So if you have a thrombosis and we do a thrombophilia workup and we find that you have severe thrombophilia, protein C, protein S, or antithrombin deficiency, then it may be helpful to test family members because those are people who, even though they haven't had a clot, we may use preventative strategies that we wouldn't otherwise around pregnancy, if that's something that could happen, or around certain surgical procedures. Similarly, if you've never had a clot, but you have a family member who had a clot and they've tested positive for severe thrombophilia, it may be reasonable to test you even though you haven't had a clot yet, so we know how best to protect you and make sure you don't have one in the future.
But it does not drive a change in your decision-making if you've already decided that you're either way on top of that triangle or way on the bottom of that triangle. That's not rationale to get the test.
Correct. So if you have already made the decision, you're staying on anticoagulation indefinitely because I think your risk is so high, you're not going to gain anything necessarily other than some information, and not that that's not helpful, but it won't impact your management, again, unless you're really thinking about APS and a choice of anticoagulant. But in most patients, it's not going to impact your management. You've already decided that patient should remain on anticoagulation, or if it was surgically provoked, you've already decided they just need 3 or 6 months of therapy. Those are the times where that's not going to influence.
But I'm loop back to the family. So I'm going to keep you on anticoagulants forever. You've had a bad, unprovoked clot. No reason to test when they say, I want to test because I'm worried that my kids might have a propensity to clot.
So should you test the family member?
Or test the family member, or yeah.
Yes. So if you have a patient who has an unprovoked thrombosis and they have children of childbearing years, then it would be reasonable to test for that reason. And really you're doing it backwards because that person whose parent had a DVT or PE and was unprovoked and could have antithrombin deficiency, maybe you'd go ahead and test them. So yes, there are situations. So again, like the ASH guidelines, be careful with them. They're just suggestions, and there's certainly scenarios around which you might expand your thrombophilia testing, but know in advance how it would be helpful. Like it would be helpful for this daughter of this patient with a VTE to know if she had severe thrombophilia.
So you test the offsprings directly, not try to
You
get
could-
there
you
via.
Could, you could do either. You could test the person who had thrombosis. The thing to remember, though, is there's 5 things we test for, right? It's a limited battery of testing. So I always say to people, even though I don't find anything, it doesn't mean you don't have anything. I only know of these disorders at this time. So it tells you you don't have the thrombophilia that we've discovered, but you could have something otherwise. So we're always careful with first-degree relatives of people with thrombosis because they're at increased risk, and that thrombophilia workup may not expose everything.
Got it. Andy, I'll throw one out to you and then open it up. Congratulations on showing 5 coagulation cascade diagrams, and I stuck with it and didn't leave. I had never really thought about the sort of try to attempt to bifurcate clotting and bleeding and see if you can target one without the other. But I got from your slide on it looked like tissue factor was involved in both clotting and bleeding. Is it always involved in clotting? Is there a mechanism for a clot always? There's something disruptive in the endothelial lining? Or I sort of thought of as a clot, you have a propensity to clot and you have slow flow, and there wouldn't be there wouldn't be tissue factor there. And that in some ways would be an argument for being able to try to dissect out which mechanism.
So that's a good question, and I think there's a limit to our knowledge. I'll answer your question this way. You absolutely don't need it, because if I put a PICC line in you, then there's nothing about that. It's all contact factor driven,
right,
as best we know. So to answer that part of the question, it's not necessary. The idea in other situations, say the atherosclerotic plaque or something else, so we're talking both arterial and venous situations, and then we're talking more on the venous side, say there could be something inflammatory going on and the changes on the surface of the endothelial cells, which we know so little about, okay, and tissue factor may be playing a role there. And while historically we've always had the drawing like I have it, which is that you see tissue factor on the subendothelial space, over the last few decades it's clear that there's tissue factor on monocytes, there are cells in circulation that can put tissue factor on the surface of them. And that's part of the thinking going on here, that very low levels of tissue factor are playing a role in thrombosis, the non-catheter ones. Okay, so we're going to leave that out. And that gets you this little starting enough such that thrombin is going to then drive you down through the intrinsic cascade, and it drives it through 11.
Okay.
Does that answer your question?
Yeah. That's great. Let's, Lakshmi.
A couple of questions from the audience. Anticoag of ambulatory cancer patients who don't have DVTs. Do you trend D-dimers to track efficacy of anticoag? And why are people not taking the correct doses being prescribed of apixaban?
Okay. I'm really glad that's not one question. Yeah. So ambulatory, so which patients with cancer should you use preventative anticoagulation? So they've never had a clot. We have a number of studies looking at this now, looking at both rivaroxaban and apixaban, using the corona risk score to help define that group of patients who may best benefit from anticoagulation. So corona risk score of 2 or greater, and there's an online calculator. It's not all I do, but I do like these online calculators. So there's an online calculator for the corona risk score that can help you identify those patients who have high-risk tumors like gastric cancer or pancreatic cancer, et cetera, plus some other features like thrombocyte, the platelet count, white blood cell, et cetera. So there is a role, yes, for carefully selected patients to receive prophylactic anticoagulation once they have a diagnosis of cancer in the absence of a documented thrombosis. And we certainly have patients on certain different chemotherapeutic regimens that result in that.
But clearly not everybody requires it.
Not everyone, and I do think that that's why this corona risk score is somewhat helpful. And some of them do include biomarkers, which is where I thought you were going with D-dimer, but it sounds like that's a separate question. But yeah, it's an area that's evolving, but there's certainly patients in whom it would be reasonable to consider. You have to consider their bleeding risk too, though.
Okay. And you want to take the D-dimer, or anybody want to?
I love myself a D-dimer, but anybody else can.
Go for it.
So you're asking, should you check D-dimers to assess response to therapy or to determine duration of anticoagulation? Or do you just want to have a whole D-dimer lecture?
Yeah, let's go ahead. We have another hour.
This is a
Whatever
audience
you want to
question.
answer.
They're asking about the D-dimer as a biomarker of efficacy of anticoagulation.
Of efficacy.
Interesting question. There are no guidelines around that at the moment. Now, do I do that? Yes. But, that's maybe don't do that at home. We can talk about that in a minute. So D-dimers, mostly we use it to make the diagnosis of DVT or PE, right, to help us figure out who should get testing. And we use it sometimes at the end of therapy to determine whether they should stay on anticoagulation, because some studies have shown serially positive or positive D-dimer after stopping anticoagulation puts them in a higher group cohort, higher risk cohort for recurrent thrombosis.
So at your branch point where you say this is someone I might stop at 3 months, you
Yes.
might stop it and then test a D-dimer a few weeks later?
I took D-dimer off the slides because I was supposed to just talk about thrombophilia, but I do D-dimer at that time in certain patients. Now, it's not perfect because in men, even if you check their D-dimer and it's negative after they come off anticoagulation, unfortunately, they are still at high enough risk that you would consider ongoing anticoagulation. It works in women. It doesn't work very well in men.
Okay.
Now, in terms of responding to therapy, I'm not aware of any studies that show you that you should track D-dimer to see if people are responding. That said, if I have someone in whom I'm worried is not responding and I have a baseline D-dimer, I may go ahead and check that. I may check it when I step down to a lower dose of anticoagulation for secondary prevention. Bit of a one-off. It might be a Minichielloism. It's not really, this isn't a data-driven practice. I don't know, Andy, if you do that as well.
No, I don't think I can add to that fine conversation. Other than to
You
say
just don't want any part of it.
I use it in highly selected circumstances.
Yeah.
I think we're about at time. Andy, one last question for you is I love the history, and I actually was not aware of the Wisconsin piece. That was kind of fun. Is the history of the drug development here that you come out with a very unwieldy thing that you give once a month sub-Q, and then eventually they figure out an oral? Do you think that we'll get to an oral?
Oh, so there were all three of them are there, and they're out there. So
Yeah.
there are oral agents in development in clinical trial now, right?
Great.
So oral antibodies in the other, and of course there are pros and cons. The nice thing about an antibody, it's basically you give an injection and it lasts for 30 days, so that's very nice. On the other hand, when you start bleeding at day 7, then you've got the issue of that something's there. So there's pros and cons with either one, but all three of those are in clinical trials.
And last one, given that this is not investment advice, but 10 years from now, do you think we'll be using DOACs, or do you think we'll be using one of these?
Oh, that's a good question. So I think we'll be using DOACs. That doesn't mean we won't be using those, just like we still use warfarin, even though we have DOACs. I don't think anything will come along that completely supplants what we're using.
So you think we might be in a situation where you use DOACs generally, but for some of the high-risk circumstances,
Right, so
the
point is
GI
that
cancer kind of person?
Everything might find its little area, and having a couple things and having different things for different folks, I think will advance it, because it's hard to fathom that something will be one size fits all.
Sounds like all of your jobs are safe. So. All right, thank you so much. That was great.